This is the Hamilton Medical G5 ventilator. It is the ventilator that's used in both adult intensive cares at St. Paul's Hospital and Royal University Hospital. It is also used in the pediatric intensive care and occasionally in the neonatal intensive care units. On the outside of the ventilator, you can see we have the graphic screen, which is a touch screen. The circuit here, as we scan down, blue is for the inspiratory side, white is the expiratory side, and we have the flow sensor attachment. We do use heated humidity on our ventilators. The heater is currently not on because we are not attached to a real patient, but it would normally be heated to body temperature, so approximately 37 degrees Celsius. As we come up the circuit, we get to this point, the patient Y. This is a temperature probe that is servo connected, therefore, to our humidifier pot. So it senses close to the patient the inspiratory gas to make sure that what the humidifier is putting out is still an appropriate temperature for what the patient is getting. The next portion is our end-tidal cuvette. We do use inline volumetric CO2 measurements. This is not currently reading, as my test lung does not produce CO2, but it does need to be in line at this portion on a real patient. The next item is the flow sensor. The flow sensor has lines attached to it. The lines and their adapters need to be pointing upwards. If they were to be flipped over and were on the bottom, there is the potential for them to accumulate condensate or potentially secretions from the patient, causing the ventilator to malfunction. So as much as we can, we try to keep them vertical from the patient. The filter and the test lung are obviously not usually in place. They are representing our patient, and we are using a filter to make sure our circuit stays clean today. So at this point from the flow sensor, we would normally attach this to an inline suction T-piece or directly to an elbow, which would then attach to the patient's endotracheal tube or tracheostomy tube, depending what they have. So that is the circuit. If we now move up to the screen itself, as I said, is a touch screen. The touch screen functions quite well, but if you have cold hands or are wearing gloved hands, it sometimes does not respond. So you have the secondary option of using this knob as a turn, confirm to change your settings, as I just changed the respiratory rate from 12 to 16. And I'm going to go back, touch, turn, confirm, back to 12 now. In terms of the graphics that you're seeing, on the left-hand side when you're looking at the monitor, what you're seeing is monitored values. So these are not set values. These are based on what the patient is actually receiving. So first on this ventilator, what we're seeing is the F total. So the frequency total. That means it is all of the breaths that the patient is receiving. As we know, I have a respiratory rate of 12 set. But if the patient was to trigger more breaths, that value will read higher than 12 because the patient is actually getting more than 12 breaths. And if I was to stop triggering, it will slowly decrease back down to my set value of 12. The next value that you're seeing here is your tidal volume exhaled. So the ventilator, via the flow sensor, is measuring how much volume it is getting back from the patient. This is a more accurate representation of what volume is actually in the patient's lungs on a breath-to-breath basis. And so this is a volume that we are very interested in, so we can ventilate at 6 to 8 mils per kilogram of ideal body weight. The next value that we're seeing is the expired minute volume. So it is just simply a multiplication of the respiratory rate that the patient is actually receiving by the exhaled tidal volume to get the exhaled minute volume. It is simply a multiplication. This is in milliliters and this measurement is in liters. That is how you get that number. The next value that we see is the P peak. So that is our peak inspiratory pressure, also known as PEEP in other ventilator models. This is showing the maximum amount of pressure on a breath-to-breath basis that the patient is receiving to their lung. The next value, as my test lung does not produce CO2, would be the end-tidal CO2. This is our preferred setup in Saskatoon Default settings can be separate for what the monitored values will read, but this is our preferred default order of monitored values. The next section we see here is additional monitored values. There are arrows here, so we are currently on page, and it is small, but if you were close to the ventilator, page 7 of 11. So if you were to cycle through here, again the touch screen, you can cycle through the various settings, or the various monitored values, pardon me, for your monitoring purposes. It will show whatever values are active for your patient. Below that, we have a somewhat simpler way to check your monitored values by touching the monitoring tab. Oops, just once. This gives you the monitored values, and again has two tabs, tab 1 and tab 2 for some additional values. Just press the X to get out of any menu. The remaining tabs are only used for setup of the ventilator and by the respiratory therapist, so are not needed for nursing to modify. On the right-hand side of the ventilator, if you're looking at the screen, are the set values. We set these values based on the patient's clinical presentation, their diagnosis, comorbidities, etc., so that it is best suited to the patient. In this current mode, which we are in APV CMV, a very common mode that you will see in our intensive care units, it is a control mode, which means that we set a minimum respiratory rate that the patient must be getting per minute. The patient is able to breathe above that set rate, and every breath that they trigger above our set rate will still be delivered with a set, in this case, tidal volume, to ensure consistency in the breaths. This mode is most commonly used in patients who are sedated, potentially paralyzed as well, or who just do not have the respiratory drive to initiate enough breaths for themselves. The next setting you'll see here is PEEP, so positive end expiratory pressure. This is a setting used to maintain recruitment in the lung. So now we're going to look at what our test lung is doing here. We are currently set at a PEEP of 5, which is a very standard starting PEEP for a healthy lung. But as we know, we don't frequently see people with healthy lungs. So you can see how much the lung is deflating breath to breath. Now I'm going to increase our PEEP with my push turn confirm knob. And you can see it deflates significantly less on a breath to breath basis now. So for people with large abdomens or specific lung diagnosis, we can recruit their lung so that it is not deflating on a breath to breath basis. We are keeping that area of the lung, or the areas of the lung, recruited to improve oxygenation and CO2 exchange in the lung. Now I'm going to drop the PEEP to 0 so you can see what a disconnect will do to the patient's lung. We like to avoid disconnecting the circuit at all times, as much as possible. And that was a sad look. So that is actually what's happening to your patient's lung. If it gets a disconnect in the circuit, the lung has nothing holding it back because we have the endotracheal tube through the patient's glottis, which would be the only, which are the vocal cords essentially. So it's the only spot that the patient is able to control their own PEEP. If we put the endotracheal tube through that as they are intubated, they are not able to control the recruitment within their lung. A disconnect in the ventilator circuit will cause that immediate collapse of the lung, and it takes quite a while to re-recruit that lung volume that has been lost. So I will put us back to a typical startup setting of 5. The next value you see here is FiO2. So it says oxygen, so it's our fraction of inspired oxygen, currently set at 30%, but can be set anywhere between 21 or 100%. As you increase or decrease your FiO2, hopefully you can hear in the background the flow that's being generated in the ventilator as it is modifying its blender to deliver that FiO2. that sound will go away once it's become accustomed to the new FiO2, but it is a normal sound. So I'll just drop that back down because my chest lung does not need 100% oxygen. Okay, now we're going to talk about some of the Hamilton Medical G5 alarms that it has. So when you're at the bedside, all alarms need to be responded to for your patient. Some of them are nuisance alarms, but they still need to be responded to. We always teach our staff and others that anytime there is an alarm, you need to look at your patient, make sure you still have good chest rise, check your vitals, make sure everything is okay. Some of the alarms are low priority alarms and some of the alarms are high priority alarms. So I'll go over the difference between the two. A low priority alarm will display all in yellow. So there is this bar at the top of the monitor and it will light up with yellow. There is the section here on the top left side of the screen. If you're just looking at the screen, it will also light up with a yellow bar and an indicator in text of what the alarm actually is. Lastly, whatever value is having an issue, that value will show up in yellow instead of in the current white writing that they are all in. High priority alarms, on the other hand, are going to all be displayed in red. So the light at the top will go red, the bar on the top left-hand corner will be red with text inside telling you what the alarm is, and then the value that's of question will also be in red. All alarms, low priority or high priority, will clear themselves once the problem has been fixed. So if the patient was coughing and then stops coughing, the ventilator will clear its own alarms. If it's something that you need to intervene on, the ventilator will not stop alarming until you have intervened to fix the problem. Okay, so first of all, I'm going to try and demonstrate a low priority alarm here. I'm aiming for low tidal volume. Okay, well, I got a high priority alarm because I got a low minute volume alarm. So you can hear the audible sound, you can see the red in the light, in the screen there, and then also the number has come red. I've fixed the problem now, so it will stop alarming on its own over the next few breaths. There, and as you can see, it has now corrected itself. And I did not have to touch any silence buttons or otherwise. All right, we'll try for a low priority alarm again. There we go, there's one. So it says loss of PEEP. That will happen if your patient is making aggressive efforts against the ventilator and they're asynchronous. Again, if I stop the issue from happening, it clears on its own. So you can hear the difference in the alarms between the low priority and the high priority and the difference in the colors of everything. Last thing I'm going to go over here is on the front of the ventilator. Down on this panel on the front are quick buttons. So on the far left-hand side, if you're looking at the screen, is your alarm silence button. If you push this, it indicates red, and up in the far left-hand corner of the screen, it is small, but what you have is a countdown from 2 minutes, and it's telling you that you have 2 minutes of silence. Low priority alarms will continue to be silenced. High priority alarms will break through this silence to alert you of an issue. If you want to cancel it beforehand, press it again and it will cancel its own alarm. Frequently you're going to want to use this before you suction a patient. So now about that increased oxygen button. Depending what FiO2 you are on, it will, unless it's 100%, if you push the increase O2 button, it is going to change your FiO2 to 100%. So we're currently on 21. If I touch this quick button of increase O2, it changes automatically to 100%. And now I have this timer counting down again from 2 minutes to indicate that I'm going to have 2 minutes of 100% FiO2 delivered to my patient. If you'd like to cancel that early, you just press again. The next button that we see here is the lock-unlock button. We tend not to leave our ventilators locked because we would like to be able to access the settings as quickly as possible if our patient was to need a change. So just for safety, we do tend to actually leave it unlocked. If it was to end up locked, it will illuminate in green, and anytime you touch the screen, it's going to beep. That was great. And you can unlock it. The next button that you see here is just a set of lungs. They indicate manual breath. So I'm in a controlled mode right now with a rate of 12. So this will be less applicable, but if I did need the patient to breathe more than 12 times, or if they were suddenly bearing down and pushing against the ventilator, what I can do is press this manual breath button just with the set of lungs. So what it's going to do is automatically then deliver an additional controlled breath, same as my settings here, to the patient. So if you watch the waveform, you'll notice it happen. And what you'll also notice in the top left-hand corner is that now my respiratory rate is higher than 12. It is as fast as I am pushing this button because the patient is receiving more breaths than my set rate of 12. Okay, the next button is a nebulizer button, on-off. We can put nebulizers, run them in line in the circuits in the Hamilton G5 ventilator. Ask your RTs and we can show you how to make this happen. Second to last button here, we have a print button. It's only going to be if we need to download any of the information stored in the ventilator, so that should not be applicable. And lastly, we have the power button. So don't worry, if you press the power button, it doesn't automatically turn the ventilator off. Your patient is still being ventilated. It asks you to confirm that you really do want to enter standby, so you would need to say activate standby in order to make that happen. If you don't want this to actually happen, if you wait long enough, the screen will just time out, or you can press the X if the touchscreen worked, or use the button here to confirm that you don't actually want that. Here is our dynamic lung, and then also a trend screen. So a lot of RTs like to have the dynamic lung up and the trend screen, but we can change any of these graphics to be what most suits us and what most suits the patient. So if you were to touch any of the graphics, it will bring up an additional screen. So then you can cycle through here, and one of the most common ones that nursing likes to see is called vent status. So if you just confirm that. Now you can see, based on your patient's ideal body weight and the settings that we have, it will tell you essentially that this is the good range. So it gives you an upper limit and a lower limit, and then it will tell you where the patient is landing outside of that. So currently what we have is for frequency spontaneous. My patient is not breathing spontaneous as they are a plastic test lung, so they are currently failing in terms of having at least 70% of their breaths be spontaneous. So you can see across the board, FiO2 is what we're looking at there, PEEP, minute volume, inspiratory pressure, so peak inspiratory pressure, RSBI, which is a factor of weaning, and we use that to determine, partially anyways, success of spontaneous breathing trials, and then lastly that amount of spontaneous breaths as opposed to ventilator triggered breaths. So that is an additional form of graphic that you can use on this screen. So this is just a close-up of that vent status graphic that I was showing you before. So as you can see now, our patient is ready for weaning because all of those silver bars are actually within that single bar graph area. Once all bar graphs are within that across area, that timer is going to come up. So we can see all the zeros there. So it's a minute timer. It just lets you know how long your patient has been in a steady state, weanable state. So on the Hamilton G5 ventilator here, it does have a feature of apnea ventilation. All ventilators should have apnea ventilation settings for their patients. So what it is essentially when you're in spontaneous mode, and as you can see on the top right of the screen, we are now in spontaneous mode versus that APV CMV that we were in previously. So spontaneous requires the patient to essentially start every breath and finish every breath with a certain level of support from the ventilator in pressure that is determined by the clinician. So when our patients are in spontaneous, the onus is on them to make the breath happen. It does have a backup though, if the patient was to become increased sedation, or if they were to for some reason lose their respiratory drive to breathe. So what it is an apnea ventilation setting. So the settings will include a controlled rate, usually a volume or a pressure. In our ventilator, it's selected as pressure, a PEEP, and an FiO2. It kicks in after a certain amount of time, often 20 seconds in the adult population and sooner in the pediatric population. So if the patient stops making efforts, which I will now do now, after 20 seconds, you will see the alarms and change in waveform. And there you go. So if you see apnea ventilation flashing at the top of your screen, you'll know that your patient is being ventilated because the ventilator has kicked in, but it also wants you to know that the patient has stopped making efforts, or their efforts are not strong enough to trigger the ventilator to supply a breath anymore. Apnea ventilation is our backup safety, and if the patient was to start breathing again, it will go back to our previous mode, and I'll show you that now. All on its own, and you can see apnea ventilation ended. If, however, the patient was to remain in apnea ventilation, it will just continue to ventilate as long as needed until the clinician comes and changes the mode to whatever is most appropriate for the patient.